Welcome everyone. I'm hoping you can all hear me. My name is Julia Priestley and I'm one of the joint CEOs of the BTF. We're delighted that so many of you have been able to join us today for what promises to be a really interesting session. Hopefully, we're hoping that this is going to be one of the first in a series of Meet the Thyroid Expert webinars. And the idea is that we bring an expert to you each time to talk about key aspects of living with thyroid disease and to answer your questions. For the first session, we're delighted to welcome Mr. Jeremy Davis, who'll be sharing his expertise on thyroid surgery with you. Jeremy is an experienced consultant ENT surgeon at the Medway NHS Foundation Trust in Kent and has a special interest in thyroid and head and neck cancer surgery. He's also one of our trustees at the BTF and the current president of the British Association of Endocrine and Thyroid Surgeons. Before we begin, I'd just like to remind you that we are recording today's session. The recording will be uploaded to our YouTube channel, so you'll be able to watch it again in time and share it with anyone you know who may have missed it. In just a minute, we'll give you a short talk about thyroid surgery. Jeremy will give you a short talk about thyroid surgery for Goiter's, Graves' disease and thyroid cancer. And he's really looking forward to answering your questions. So we'd really like to encourage you to type in your questions into the Q&A panel, which you should see at the bottom of your screen. There isn't a chat function, which I think has been disabled, but please type your questions into the Q&A panel and my colleague Cheryl and I will go through the questions and pass them to Jeremy later in the session to answer. There may be a lot of questions, so please don't worry if we don't manage to get round to your question. We will let you have details of how you can get in touch after the meeting and send your questions to our medical query answering service. And finally, just a reminder that Jeremy will only be able to answer questions on a very general basis. As always, if you have a specific question about your own condition, it's always best to consult with your own surgeon, a doctor or medical team. So before we hand over to Jeremy, I just wanted to say a few words about the British Thyroid Foundation, or the BTF, as we're known. We're a membership organisation which was set up in 1991, and we're dedicated to helping you better understand and manage your thyroid condition. Some of the ways we do this are by working with patients and medical professionals to provide reliable information and evidence-based information. We're able to put you in touch with others who have a first-hand knowledge of thyroid disorders. For example, our telephone contacts, our local support groups, and our Facebook groups. And we fund research into thyroid disease as well. And so far, we're very proud to have invested over £500,000 into the research to improve treatment outcomes. We're delighted to have awarded our 2020 Research Award to a project looking at the genetic causes of medullary thyroid cancer. And we also host information events, providing opportunities for you to meet other people living with thyroid disorders and to listen to medical experts. In the past, of course, these have always been in-person meetings, but like everyone else, we're working out new ways to adapt and to deal with the current situation. And so hence we're here today with our first online webinar, which we really hope will be a successful way of engaging with many more patients. We'll give you details of further sources of BTF information and support at the end of the webinar. But for now, I'm delighted to hand over to Jeremy to talk about thyroid surgery.
So welcome everybody. I always think that it's a bit of a misnomer to say that I'm the expert, because of course you as the patients are the people with the real expertise, because you've had treatment for thyroid conditions and know what those treatments can involve and what the outcomes can be. I'm an ENT surgeon. I train in head and neck surgery. I work in a medium-sized district general hospital and mainly undertake thyroid and parathyroid work, but I do have other responsibilities as well. On a national level, I've chaired the SAC in otolaryngology. That's the organisation which sets the standards of training in ENT. And currently, I'm privileged to be the president of the BATS, the British Association of Endocrine and Thyroid Surgeons, and I'm really enjoying my time as a trustee of British Thyroid Foundation as well. So why do surgeons offer thyroid surgery? Well, one of the more common reasons is around cancer, but actually we do a lot of operations that turn out not to be cancer. The difficulty being that until we've operated, in many cases, we don't know whether a nodule on the basis of the preoperative diagnosis is definitely malignant or not. But that's a very common reason for doing surgery. Thyrotoxicosis, normally after failed medical treatment. The trend nowadays is to offer radioactive iodine first, but there are some patients for whom radioactive iodine isn't suitable or hasn't worked, and particularly those perhaps with thyroid eye disease, then that can be a relative contraindication to giving radioactive iodine, so we use surgery. And then obviously very large benign swellings, and historically, if you just type goiter into Google, you will come across pictures such as this in the archives of St Bartholomew's Hospital, going right back in time, so that this is not a new disease at all. What do I find difficult and what keeps me awake at night? Actually, it's not difficult if I've got a clear-cut decision to offer surgery. So if I've got a woman of 30 with a 2-centimeter nodule in one side of the thyroid, and the biopsies show that definitely is, say, a papillary thyroid cancer, then that's pretty easy decision making for both myself and the patient. But there are lots of areas where we're not quite sure what is best to recommend, and the patient may have some difficulties making up their mind as well, and it may take several consultations before we come to a conclusion which hopefully is the right one for that individual. And then minimizing, when I do operations, the complications, and the two which worry me in the short term, and which we do see from time to time, are bleeding, which can be severe, or infection, and in the longer term, the problems which can arise from having low parathyroid and consequent low calcium levels, a vocal cord palsy due to damage to the nerves. And actually, sometimes you do a beautiful operation and the patient seems absolutely fine, but they just never feel quite right again. And there may be some people in this webinar who are in that situation, and that can be difficult. How do I know what my own outcomes are? So about half of UK thyroid surgeons contribute to the national database. And if you go to the BAETS website and look under audit, and then I think it's surgeon outcomes, if you click on that, then you can either look by individual surgeons or by local hospitals. And as long as the thyroid surgeons locally are contributing to that, then you can look at their results in terms of the numbers of operations they do, how long their patients stay in hospital, and I believe bleeding is on there. There are some other markers which worry us, such as the recurrent laryngeal nerve palsy, and that isn't in the public arena there, because there's great variability amongst surgeons as to whether the voice box is checked following surgery, and so it's a difficult thing to publish, because I can know my own personal rate, but a different surgeon may not come from an ENT background. Their patients may not so often have their voice boxes checked after surgery, and therefore may get different figures. Who are thyroid surgeons? So at the moment, it's about a 50-50 split between those who originally had a general surgical training or an ENT training. And as trainings become more directed, it's probably moving towards more ENT. But within general surgery, there are still endocrine surgeons who specialize just in endocrine surgery affecting the neck and the adrenals. And these are the general surgery thyroid surgeons of the future. And there are a few maxillofacial surgeons coming through undertaking thyroid surgery. All surgical specialties have a new teaching format coming out next year. It was due this year, but COVID has delayed it. And in general surgery, there's continuing provision for training endocrine surgeons. And in ENT, there will be a defined special interest in thyroid and parathyroid surgery, along with 6 other branches of ENT surgery. So it'll be mainly those who've chosen to spend their last 2 years of their surgical training, which is about 10, 11 years after they qualified, just learning thyroid and parathyroid surgery, who will be the thyroid and parathyroid surgeons of the future. The same for the general surgeons. It's the last 2 or 3 years of their training. They specialize just in that endocrine surgery. It doesn't mean they haven't done it previously, but they'll just spend 2 or 3 years pretty much just concentrating on that. What are the challenges? I speak a lot to patient representatives of the various thyroid charities, and hear that there is a greater number of patients currently contacting the thyroid charities because they've had a confusing consultation with their clinicians, sometimes a surgeon, sometimes an endocrinologist or an oncologist. And one of the sort of positives to come out of what's happened legally in the medical world over the past 3 or 4 years, but also in some cases a negative, is the Montgomery legal case. So up until probably 10 years ago, I would probably make what I felt was a best interest decision for the patient and let them know that that is what I thought we should go ahead with treatment. But very much the pendulum has now swung that I need to give my patients all reasonable treatment options, including the do nothing option, go through the risks of each one's and the benefits of each one's, and then really ask the patient to make a decision. And that can be really difficult, again, if you've got a relatively young individual, a man or a woman, you know, in their 20s, who you found a small thyroid cancer on, and perhaps it's not that small, perhaps it's big enough that there is a discussion about whether you take out half the thyroid or all the thyroid. And I think it can be quite difficult, because often the decision ends, what would you do? You know, what would I do? But we have to go through that. And I think it can be confusing. And within the NHS, in normal times, pre-COVID, then the pressures are such that it's difficult to have 2 or 3 consultations to do that. Ironically, COVID has actually helped me in the more complex discussions, because I'm doing a lot less work. I'm doing a lot less routine work. And therefore I can spend more time with patients who are needing urgent surgery. What does a diagnosis of thyroid family disease mean for my family? I mean, that's a question I'm often asked. And some families are prone to thyroid disorders, so it's very common to get a family history, often on the female side, but it can be on the male side. But it doesn't have to be the same thyroid disorder. So you might have an aunt who had low thyroid hormone levels, a niece who had thyroid toxicosis, and a nephew occasionally who'd had thyroid cancer. There are a very few thyroid cancers which are truly familial. There's something called medullary thyroid cancer, quite rare, but some people will have that as a genetically acquired condition, and then we need to look at the whole family. But that's uncommon. We need to be aware of it as doctors, but for individuals with the thyroid problem, unless the doctors have raised it, it's always worth asking, but the vast majority will not be a genetically acquired disorder that can be proven by gene studies. And because thyroid disease is not the commonest of illness, then even if you double the risk by having other family members with that, then it's still a relatively low risk. So as Julia said, I'm welcoming your questions. That's the whole aim of how we're trying to run this, and I can discuss general issues. I'm really sorry I can't give you a specific answer to a narrow clinical question. But where we're going to go on to now is that Cheryl and Julia are going to take it in turns to take your questions. Now then, what we're expecting is themes of questions, so they may clump together several questions in one theme. So, Julia, I'm going to stop sharing my screen and come back to you now.
Thanks very much, Jeremy. Really interesting, and covered lots of great ideas to start us off today. I'm going to start off with a question we're often asked at this when we have medical queries. If someone has a multinodular goiter, does it mean that they have to remove the whole thyroid gland, or could it be appropriate to just have a partial removal? How is it decided?
Okay, so I'm going to answer this in several ways. Obviously, a small multinodular goiter, if investigations have shown a low risk of any malignant change, and that would normally be the case with a multinodular goiter, you might need to do nothing at all if it's not causing them any discomfort and the cosmetic element is minor. Especially in older people who may be getting some discomfort from it, but very mild discomfort, and are not worried about the cosmesis and are inevitably more prone to complications from surgery, we might look at offering some radioactive iodine treatment, which will shrink it maybe by 10 or 15%, not in everybody. Again, you need to do some tests initially to see if radioactive iodine can be appropriate, but that may avoid surgery. If you come on to surgery, then sometimes you get a multinodular goiter, which is just affecting one lobe of the thyroid, and then it's absolutely appropriate to just take out that one half of the thyroid and leave the other in place. But the final bit, which is probably really what the question is if it's both sides of the neck and you can't do anything about it, then the current feeling is very much it's better to remove the whole thing. Because if you do an operation which used to quite commonly be done, which is a subtotal thyroidectomy, where you leave deliberately quite a lot of thyroid tissue behind, then in many individuals that would then regrow. And if you're doing the surgery on the same side of the neck for the second time, then the risk of complications, the risk of damaging the recurrent laryngeal nerves or taking out the parathyroids or irreversibly damaging them is much greater than at the first time operation. So really, as a surgeon, I only want to be in one side of the neck once. So I don't want ever to have to risk going back there. So that is why if somebody is having surgery for goiter, it would normally consist of a hemithyroidectomy, taking out just the big half if it's only big on one side, or a total thyroidectomy. So I hope that answers that question.
Following on from there, it's related to the question you've just had, but somebody has had a hemithyroidectomy for nodules on the left side. The right side is working perfectly fine, but can the right side now develop nodules or reduce its function in the future?
So the answer to both of those is yes, but fortunately not very likely to. So NICE published some guidelines for benign disease last year in 2019. They're published on the NICE website if anybody wants to have a look at them. And one of their recommendations is anybody who's had half their thyroid removed should have an annual thyroid function test, because if you do have half a thyroid, then yes, you are slightly more likely over time for your thyroid hormone levels to become inadequate. And certainly, in addition, anybody in that situation, I personally would always have said when I was discharging them back to the care of their GP, that if they felt tired, if they felt a bit older than their chronological years, to make sure they had a thyroid function test performed. In terms of what's the risk of needing in a benign goiter where you've just taken out one side to then operate on the other side, anecdotally, it's uncommon. I mean, I've been doing regular thyroid surgery for probably around 20 years, and I could almost count on the fingers of one hand the number of patients I've had come back for that second side surgery. So there's no such thing as never in medicine. Everything that can happen does, but it's fairly uncommon for the second side to become goiterous. We don't quite understand why, but it's fairly uncommon.
Thank you. Here's another one. We've had several questions relating to thyroid eye disease, and it's something we often hear from patients who call us. Will having thyroid surgery reduce the risk of someone developing thyroid eye disease? So they had Graves' disease, but no sign of thyroid eye disease. In the future, following surgery, will those antibodies still kick in? The thyroid eye disease antibodies, may they kick in, or will actually having the thyroid removed altogether reduce the likelihood of that happening?
So I think we've got to be careful in answering this. So what we know is that when we take out the thyroid and thyrotoxicosis, then over time, the antibodies, and particularly the TRAB antibody, does decline in most people. And those are the antibodies which trigger the thyroid eye disease. And we also know that if somebody has pre-existing relatively severe thyroid eye disease, then giving them radioactive iodine can occasionally make that worse, which is why it's one of the reasons why we would offer surgery. I think obviously I deal with a lot of patients with thyroid eye disease, but it tends to be the ophthalmologists who are where people have had Graves' disease, presented with Graves' disease. They've normally had it for a couple of years, having medication, and then the time comes for a choice of surgery versus radioactive iodine. I'm not aware of any big worries about giving radioactive iodine at that time, which of course doesn't remove the thyroid and leaves some normal thyroid tissue, in terms of whether the patient is the individual's more likely then to develop thyroid eye disease down the way. So I think surgery can be more helpful than radioiodine if you've already got the thyroid eye disease, but I wouldn't be going for surgery just because you were worried about getting thyroid eye disease at a later date.
We've had several questions about this. How long does it take to recover after a thyroidectomy? And one person in particular who competes in triathlons wants to know how long it will take to get back to full fitness level.
It's very variable. So I would, if somebody's working, I would normally sign them off work for 2 weeks following a total thyroidectomy, but warn them that they might need a third week, and that's just a medium-sized thyroid. If somebody has a very big goiter going down into the chest, then you can predict it's going to be a lot longer. One of the difficulties about thyroid surgery is that probably 80% of individuals will have their operation and make a swift and uncomplicated recovery. But we know that some will, probably about 1 in 5 will have temporary problems with their calcium balance, and about 1 in 20 will have long-term problems with their calcium and parathyroid levels. And you know, unfortunately, complications in the best will do occur. I normally have a low level of post-operative wound infections, but that doesn't mean that I never have somebody with a post-operative wound infection. And if somebody gets that, it's going to take longer because we've got to get that to settle down. It can mean a readmission to hospital, sadly. But if it's completely uncomplicated, then normally I would be saying return to relatively normal after about 2 weeks, return to more exercise at 4 weeks. I always think about swimming, that I'm always a bit worried about people doing breaststroke or backstroke where the neck's a bit more pushed backwards until about 4 weeks afterwards. Triathlon, I think it's a matter of taking it gently, but probably about 3 months until, you know, really fully training and putting that behind you. But building up after the first month.
Why is it that targeted treatment to blast and remove papillary thyroid cancer completely without the need of surgery has not yet been developed?
You can't know the full nature of a tumour unless you've removed it with normal thyroid tissue around it and allowed the histologist to look at the whole thing. So when we're looking at fine needle aspiration cytology, or even what's called core biopsy, a bigger biopsy, then to be absolutely certain of what you're dealing with, that there's nothing like having the whole lump to give to the pathologist so that you can see whether there are any more worrying features within that particular tumour which might make a team offer more treatment than just taking out half the thyroid. The next thing is where newer techniques are being used for ablating, for instance, nodules, it's not without morbidity. So it's a learning curve. It's still, a lot of it's still in the research arena, and you can damage a recurrent laryngeal nerve from heat, from blasting a nodule, just as much as I can damage it at surgery. So I'm not saying it won't come in the future, but where it is happening, it's very much just in the research area, certainly in the UK at the moment.
Thank you. Here's a thyroid cancer question. If a patient has thyroid cancer which has been confirmed beforehand, what's the criteria for watchful waiting, and how do you find patients tend to react when you offer them the no treatment option?
A very good question. With small thyroid cancers, say you've got a 5 millimeter thyroid cancer and possibly a little bit larger, then and it's papillary, and the likelihood is that it will sit there and it will never cause any problems. The difficulty we have is that we do see some patients who've presented with quite widespread thyroid cancer within metastatic thyroid cancer affecting principally the lymph glands in the neck, and you go looking in the thyroid and there is a very small, tiny little thyroid cancer to start with. So if I know somebody's got a very tiny thyroid cancer, then I can't be certain that they're not going to have a problem. Obviously, in the decision-making process, then you'll take into account their age, their gender, because men who have thyroid cancer tend to potentially do a little bit worse than women. And at the moment in the UK, there doesn't seem to be a huge appetite for watchful monitoring. Now, there will be individual teams who are offering it. I've certainly offered it to patients. I've yet to find a patient who said, yes, please, I'd like to be monitored, with the exception of patients who have other tumours, or other need for urgent medical treatment, or particularly the elderly. So if somebody's in their mid-80s, then they may well say, well, yes, no, I'm happy to take the risk because it'll be a bigger risk to me than if I have an operation.
The question that I've not heard before, can your thyroid regenerate after surgery and begin to function again?
Well, not fully regenerate, but the more common operation done 20 years ago, the subtotal thyroidectomy, then yes, quite a lot of thyroid was left behind. And if there was a tendency of that to become nodular and goiterous, then it would indeed expand and potentially and get bigger. It's unlikely to regenerate in most people to the extent that thyroid, if somebody needs thyroid replacement after thyroid surgery, it's not very likely to regenerate to the extent that they no longer need that.
We've got some questions coming in about alternatives and kind of future alternatives, and we know that there are lots of patients who are worried about having scars post-surgery. I've had a few questions in the last 6 months about transoral thyroidectomies.
So the first real group of people who got involved with this were the Koreans, who are particularly worried about neck scars, and they were using robots to go through the axilla or armpit, principally to take out the thyroid. It's really only suitable for relatively small thyroid, so it can be used for some cases of thyrotoxicosis or for relatively small nodules which are worrying. If somebody's got a big goiter that can be seen from the end of the room, then it's probably just not going to be suitable. And there were problems with the robotic approach. It's a long operation, and some patients ended up with damage to the nerves to their arm and had problems moving their arm afterwards. So not a risk-free problem, and indeed if they then went on to wear a bikini, then they just transferred the neck scar to their bikini area, just where the straps came over on the arm there. And then yes, transoral. So transoral, again, it's only suitable for relatively small thyroids. At the moment, it's just taking off in the UK. There's an ENT surgeon called Ron Murthy in Wexham Park Hospital, and he's hoping to start that soon. He's done the training. There's a mentoring session that he's done, and so it's in its infancy. I don't think it'll be suitable for all thyroids, but it may well be a scar-free option. There's also video-assisted thyroidectomy, doing it through very small scars. When people have looked at scars, if somebody's got a scar on their neck, then obviously if it's thickened, then there's a bigger worry, but the actual length of the scar doesn't seem to make so much difference in their perception of their scar in the longer term. And the video assisted, again, is suitable only for relatively small thyroid nodules. Again, if you've got a big thyroid, then you need a big enough incision to get it out.
We've had a few of these questions regarding multinodular goiters. When the goiters are on both sides and continue to grow and then become painful, and it's difficult eating and swallowing, and the person starts to lose weight, at what point do they decide on surgery? And is it is it people that with only a cancer diagnosis that can have surgery anyway?
That's a really difficult one, because I would have a thorough discussion, but what we call pressure symptoms, i.e. the discomfort, is a recognized indication. I'd want to just carry out some tests to make sure that there was no evidence of any cancerous change within the goiter. You just need to do that. It's very rarely that there is. So what I would say to somebody who feels that they're not being offered the treatment they would like is just consider asking for a second opinion. That can be, I mean, it's nice to go back to the first clinician, perhaps once, and have a discussion and say, look, I'm a bit uncomfortable about this. Can I understand why we are where we are? But if that isn't working out, personally, I always find it very helpful to offer those individuals a second opinion and to discuss with them who we use for that second opinion. But I know that doesn't always happen. So what I would say is, if you're not happy with the opinion you've been given, then go and get one further opinion, and your GP should be able to help you do that.
Can you tell us, is there a correlation between the size of a thyroid nodule and the complexity of the surgery, or the risks post-surgery? Does a large nodule usually present more difficulties, or is it not as straightforward as that?
I think if it's a single nodule up to about 6 centimeters, then it doesn't make a huge amount of difference. But certainly where you've got multiple nodules and it's very large, then it does make the surgery technically more challenging, both in terms of preserving the parathyroids and also in going around all the blood vessels. And it can also make the anaesthetist task a little more challenging.
I'm not sure whether you'd be able to answer this one, or whether it's for a voice therapist. But if the voice has been affected after a complete thyroidectomy and is not improving with voice therapy, what else can be done?
When the voice is affected after thyroid surgery, the most common reason is that one or both recurrent laryngeal nerves have been damaged. Now, then they may have been just bruised, in which case over time they should recover, although it's very important to get voice therapy at the earliest possible time to help the voice to recover. And people can have swallowing problems as well. So if you have paralysis of one side of the voice box, it's more difficult to swallow. It's easy to cough on swallowing because water can be going the wrong way. And then over time, there's normally a period where you would look to use speech therapy, partly because you're hoping that vocal cord's going to recover, unless you know you've actually had to resect the nerve to the voice box, which occasionally happens with cancers, but most often the surgeon believes the nerve to be intact at the end of the operation, but just not functioning. And so working with the speech therapist for the first few months, if at that time it becomes clear there's not improvement, then there are specialized voice clinics. So about 20 years ago, I used to run a voice clinic. My career took a different turn, and I've got a really great colleague who runs our local voice clinic. And actually, I will always notify him if I hear of a thyroid patient, either who I've operated on or colleagues operated on, in trouble with their voice. So as well as the speech therapy, we will get them through to the voice clinic. And normally a voice clinic will have specialized equipment which is better placed to diagnose, for instance, if there's damage to the superior laryngeal nerve, which is the other nerve to the larynx, or just if you've had a big goiter, then just the scar tissue around the larynx as well can cause voice problems. And so if somebody has ongoing voice problems that have not responded to speech therapy, and that's been going on for some months, then I would say seek out a referral to the local voice specialist. And the provision varies a lot around the UK, but it's normally possible. Large ENT departments nearly all have a voice clinic, and so it should be possible to track somebody down, or for your GP to track somebody down.
That's really useful for us to know as well, to tell people in the future. There's somebody here who said they had surgery 7 weeks ago to remove their thyroid for Graves' disease, but they've still got Graves' disease symptoms. How long should they expect to put up with that, with those symptoms, before it settles down? And this is also important because a lot of patients have been telling us they can't get back to have blood tests or for follow-up appointments because of COVID.
Yeah.
And it's difficult to get the follow-up, and they don't know how long they've got to put up with things before they push themselves forward.
I wish I had all the answers to that. So it depends what symptoms. Obviously, the symptoms of that you get from high thyroid hormone levels, which are typically anxiety, raised heart rate, intolerance to heat, they should settle relatively quickly. We calculate the dose, the replacement dose of levothyroxine in most patients at a dose of around about 1.6 micrograms per kilogram, and put it up or down to the nearest 25. Different individuals do need blood tests to just adjust that dose. So I think the key there, if they're not feeling quite right, is to see either through their endocrinologist, their surgeon, or their general practitioner, if they've not had some fairly recent blood tests, to get some thyroid function tests done. One of the problems about doing thyroid surgery for thyrotoxicosis is, as I alluded to right in the beginning, there are some people who just for quite some time afterwards just still don't feel quite right. And you can look at all their numbers, and their numbers, when I look at the, the blood numbers around the TSH, the free T4, the free T3, and they all look fine, and yet the individual, which is what's really important, just doesn't feel quite right. Normally it settles, but there will be people, and I wouldn't be surprised if there are people on this call where they're ongoing, they just don't quite feel as well as they did prior to their Graves' disease starting. Some people slightly regret having had their Graves' disease treated because they feel quite good with these very high thyroid hormone levels. The problem about ongoing Graves' disease is it does cause other problems later in life. It can cause heart flutter, it can cause osteoporosis. So there are good reasons for treating it. And almost certainly if it was left untreated, people would run into problems down the way, but it might not feel like that.
Can I just ask a follow-up question about the COVID? We have had a lot of questions about it, and people in the Q&A are asking as well. We understand that many routine surgeries were cancelled, but that the services are getting hopefully somewhere back to normal now. In your experience, are you able to say how things are going, how back to normal things are from your colleagues around the country?
Yeah, so it's hugely variable. The first thing is that there has been some national guidance which applies to England, and which the other countries of the UK are tending to follow to some extent, around the precautions we take to minimize the risk to patients from COVID. And so the standard practice is to fully self-isolate for 14 days prior to any operation, and then have a COVID swab done within 72 hours. There's been quite interesting stuff about swabbing of surgeons and the surgical team. So I've been through a period where I'm being swabbed every week, but for various reasons, then we may be moving away from that, and just making sure that when we're in hospitals, we're wearing PPE, not just to protect ourselves, but to protect you, the patient. So as long as your surgeon's well covered up, then even if they did have asymptomatic COVID, they almost certainly wouldn't give it to you. In terms of services running, I had an email just the other day from a senior thyroid surgeon in a big city within the UK, saying that his service had got going, but he'd heard from a colleague, and this was about patients with thyrotoxicosis needing surgery, a colleague in a neighbouring big city whose healthcare organisation was still saying, well, no, we can only continue to do life and limb type surgery. I think the worry is there's a further wave of COVID. There's no doubt that COVID was, at its worst, incredibly worrying and disruptive. I was lucky. My relatively small organisation was able to access a local independent sector provider, and so I've been operating throughout the COVID period on non-COVID patients in that area. but those contracts are starting to come to an end. So I'm now moving back to base. Within the hospitals, all hospitals are trying to create green zones. So that's zones where only patients who've been pre-screened and low-risk staff go in. One of the problems is around surgeons that there are some specialties where it is practical to keep a group of surgeons away from any emergency patients, but for most of us it's not practical. So I can be treating patients with known COVID, but 1 week, and then treating elective patients the next.
About how surgery can affect the calcium gland. I think a few patients are obviously worried about having surgery because of this reason, but they wanted to know what the long-term effects of the calcium gland being damaged.
Okay, so if you're just having half your thyroid removed, then you have 4 of these parathyroid glands. In most people, some people have 5, some people have 3, but the vast majority of us have 4, and they sit behind the thyroid. So they're in about the positions of my fingers, deeper in the neck, behind the 2 halves of the thyroid. As long as you've got 1.5 of those functioning or 2 functioning, then that's fine. So they produce parathyroid hormone, and that looks after the levels of calcium in your blood. So if you're only having half your thyroid removed and you've not had the other half removed, then the chance of you having problems with calcium or parathyroid hormone afterwards is very small. However, when you have the whole thyroid removed, or you've had half removed previously and now you're having the second half removed, then there is a risk of ending up with low parathyroid hormone levels. We know from the national registry that the risks are probably higher than those which people used to think. So surgeons historically have tended to publish patients on their results if their results are quite good, which may not give a true picture of the average of surgery across the board. So we know from the national audit that between 1 in 3 and 1 in 5 people undergoing a total thyroidectomy will have a short-term need for some calcium supplements, and somewhere between 5 and 10% will have an ongoing need. Now, in some of those individuals, it may be just a small level of calcium supplementation, either with calcium tablets or vitamin D type tablets. But in others, they may have very little parathyroid function afterwards and need much bigger doses. And there's something about parathyroid hormone other than the calcium. So we know that by giving medication, we can get the calcium right. But the individual themselves, if they've got low levels of parathyroid hormone, may just not feel right. Your surgeon should know their own rate, as long as, I think it's a professional duty to know our own rate of low parathyroid hormone and low calcium. Additionally, it's more challenging both with very big goiters, but also with thyrotoxic patients, and finally with cancer patients having more extended thyroid surgery to include the lymph glands behind the thyroid. So there are 3 groups that we particularly are concerned about potentially having low calcium and parathyroid hormone levels afterwards. How do I personally try and minimize the risk to that? Well, I use loops when I'm operating. BATS ran a webinar very recently because there are starting to come through techniques of immunofluorescence on the parathyroids to try and make them light up so that we can see them more easily. The problem is a normal parathyroid is a tiny thing, and its blood supply is very tenuous and is shared with the thyroid. So in taking it off the thyroid, it's easy to damage the blood supply. So to wrap up the question, it is a significant concern. I think discuss with your surgeon, but you can choose the best surgeon in the UK, and they cannot guarantee to you that you will not have low calcium or parathyroid hormone levels afterwards. So I will quite often have a conversation with a thyrotoxic patient who's got a couple of young kids, for instance, and therefore they don't want radioactive iodine. But I will always, try and have the discussion. There are, just to be clear, there are some patients with thyrotoxicosis who cannot have radioiodine for medical reasons. They've got bad thyroid eye disease, or their thyroid, their Graves is so poorly controlled. But there will be some who do have a choice and will be worried about being away from their children for a week or two versus the possible complication of needing to take medication for life in addition to your thyroid medication. But people will sometimes choose surgery nevertheless, you know, even but I think it's really important to have had that discussion.
Yeah, I think so long as people are aware of it, then it's, you know, they know the risks, and they know what can happen.
But I would say, you know, do have an open conversation with your surgeon, including asking them if they could give you some idea of what their personal risks are.
We usually direct them patients to the BATS website and the audit there. It's something it's quite tricky for patients to do, to question your surgeon, but it's a very important thing to do, and it's the right thing to do, and it's part of the conversation that needs to be had, isn't it?
Absolutely.
Thank you very much, Jeremy. We've run out of time for questions now. I'm going to, that was really interesting, and you must be exhausted now. You've covered a whole range of topics. Thank you very much, Jeremy, and also to Cheryl for your questions, and Sophie for helping us as well with the questions. And thank you so much to all the participants today who've put an amazing range of questions to us. We didn't get through all of them, I'm afraid, but we will, but we'll, in follow-up email, we will be sending you a link to show you how to get in touch with us for medical queries that you still have that you'd like answered. If you joined late or didn't have time to write everything down, we'll be shortly uploading a recording of the webinar to YouTube, hopefully, if that works smoothly, and then you can view it again in your own time. Again, the link will be in the follow-up email and also published on our website. On the BTF website, you will find a whole range of resources, including patient leaflets, videos, patient stories, and details of our support network. So please go to that for further support. And as this is our first webinar, we're really keen to get your feedback. I'm sorry about any technical hitches there were. We've all learnt a lot from it. Let us know what topics you'd like us to cover in the future. Perhaps you'd like to hear more from an endocrinologist to tell us about ongoing management post-surgery, or would you like us to hold a session specifically about thyroid cancer, for example? In the follow-up email you'll get, you can find if you reply to that with your comments and suggestions, we'd be very grateful. And if you have enjoyed today's session, we'd be very grateful if you consider supporting our work by making a donation or becoming a member of the BTF. Like every other UK charity, our fundraising income has just plummeted overnight as a result of COVID. It's just £25 or £15 for concessions each year to become a BTF member. If you do join, you get our newsletter 3 times a year, which is packed with updates about thyroid research, treatments, and patient stories. And you'll also receive regular e-bulletins and priority access to medical query answering service that we have. And you'll be helping us fund research to benefit future patients. So if you're able to donate or join, please follow the links from our homepage on the website. Once again, thank you very much, Jeremy, for giving up your time this evening and answering our questions, and to everybody who joined this meeting and put questions to us. We hope you will stay in touch with us and look forward to you taking part in our future events. Thank you.